Good afternoon, everyone. Welcome to today's PG lecture series on endocrinology. We have Dr. Nitin Kapoor with us to talk on an update on obesity management. So, Dr. Nitin Kapoor completed his DM and postdoctoral fellowship in endocrinology in Christian Medical College, Vellore. And then he did his PhD research on clinical and genetic indicators of obesity from the University of Melbourne, Australia. He has more than 300 PubMed index peer-reviewed publications in national and international journals, and his keen area of interest are in the field of obesity, metabolic syndrome, pituitary disorders, and metabolic bone disease. So I am sure we are going to have an excellent lecture on the current topic. Over to you, sir.
Thank you so much for that introduction. So in the next couple of minutes, I'll take you through this topic of management of obesity and update. And when I thought we should talk of an update, we'll essentially looking at different things in obesity management. There are a lot of things that we could talk about in terms of update, but if there's one specific thing that I would say is essentially the most hot, or something that's really something that we really need to update ourselves on day-to-day basis, that would be anti-obesity medications. So I'll keep my focus on that, but I'll cover a couple of other things as well. I thought I'll cover this in 5 brief domains, the entire topic. First of all, talking about what is the relevance and the current day need of all these newer anti-obesity medicines that we are getting into the market. What are the pharmacotherapeutic management strategies, the targets, or the mechanism of actions of these drugs, the conventional ones which are already available. We'll talk in detail about the novel GLP-1 RAs that are either already there in the market or in the pipeline. We'll talk about how to use them, what is their indication, when we start, how we follow up, what is the role of other medicines in obesity management. And just before I close, we'll also talk about the upcoming role of genetics and the gene-specific drugs that we now have for obesity management as well. So starting straight with the need for this particular topic, I think all of you would agree with me that obesity has reached pandemic proportions globally. When we talk of data from India, this is data from the National Family Health Survey. This was from NFHS 4, where we found that about 35 to 40% of the Indian population is either overweight or obese. I saw one of the questions that were asked to you in the pretest that talked about the WHO guidelines for obesity diagnosis, and for the Asia Pacific region, anything above 25 kilogram per meter square is obesity, anything between 23 to 24.9 is overweight. So this is everybody above 23, about 40%. So this was NFHS 4, but we also have NFHS 5. But specifically looking at data from Tamil Nadu, what we find is there's a remarkable increase in the prevalence of obesity, especially in men. It's gone up by 75%. So that's huge. And when we look at data from NFHS 5, which was 5 years later, whatever numbers we had in late 30s has now become early 40s. So 40 to 45% of the Indian population is currently overweight or obese. So the point that I'm driving here is that it's not uncommon that you'll have in your clinic patients just walking in and sitting and asking, doctor, I want to lose weight. And that's the only complaint that the patient would have. So all of us as physicians need to be definitely trained well enough to handle obesity alone as a disease without any comorbidities. When we looked at data from Vellore, we'll come to that. But to complicate things further, our phenotype of obesity is also very different. I mean, we definitely have more body fat, we have more centripetal obesity. We also have this phenotype of so-called normal weight obesity, wherein we may have normal BMI, but a higher body fat percentage. And that is also a big problem. So yes, obesity is a big problem. We all agree to that. But the good thing that has happened over the past few years is that our understanding of the disease has also improved several fold. Today, we understand obesity as a disease and no longer just somebody who's eating more and walking less. Today, we understand that somebody is eating more because they have changes within their hypothalamus, within their appetite centers as to how hormones are different. And the appetite center is regulated by all these different hormones that you will see on the slide, and how this really modifies the appetite of a given patient. And it's just not right to blame a person just because he is eating more or walking less, he's getting obese. It's driven as a disease, like for any other disease. Like for diabetes, we would say that the insulin is not working. That's why the glucose is high. And it's just not that because somebody's eating more sweets and that's why alone diabetes is happening. Along with this, yes, there are modifiers from the gut. Gut hormones play a role, adipocytokines play a role. And to top it all, the metabolic, behavioral, and environmental factors also play a role. And this is, in short, a very comprehensive, understanding as to how we understand obesity as of today. So that is a knowledge that has really heightened our ways to manage it, and our guidelines have changed remarkably. 10 years before, what guidelines for obesity management we had, they were mainly BMI centric. They were just saying, okay, patient comes with this BMI, our aim should be to bring down the BMI by X%. But that has changed over time. Today, we look at the patient as a whole, trying to understand as to what complications the patient has and try and improve the overall health of the patient than just reducing a number of weight or BMI. The two main guidelines from India that we've had on obesity, one was by the Endocrine Society of India, another one by RSSDI, which talk about obesity management. And what they all endorse today is that overall, when we manage obesity, our aim is not just weight loss, but to improve the patient-centered health outcomes, to improve the quality of life of the patient. At the end of your treatment, if your patient has lost 5 kgs, but the patient is terribly depressed because the patient is so engrossed in just counting calories and not able to do any kind of things that they like, and they go into depression, then that's definitely not the way forward. Overall, you have to improve the quality of life of that given patient. So that's what the guidelines today talk about in terms of quality of life. When we looked at quality of life data from the obesity clinic here in Vellore, definitely most patients with obesity, this is obviously BMI more than 35. So most of these patients did have poor quality of life. But many times patients do talk about their comfort with food, their experience with dieting, sometimes very traumatizing. And that contributes to their poor quality of life sometimes. And that is something that needs to be addressed. So definitely lifestyle is important, but at the same time, there is a role of other medicines and surgery and other therapies for obesity, especially in people who've got morbid obesity. Right. So that's why we need anti-obesity drugs. And let's talk about what are the targets and the mechanism of action of the conventional drugs that are now available. So the way we had the Omnius octate of diabetes, now we also have Omnius octate for obesity. But at this point in time, we really don't have all the targets for obesity management fulfilled in the Omnius octate. I think the two drugs that were or are available in India, at least who've somehow sustained the test of time, is Aldi and liraglutide, also not in the full dose. When we look at the Indian regulations, we see that Aldi is approved for management of obesity in India. Liraglutide, we just have up to 1.8, 0.6, 1.2, and 1.8. It's not approved for obesity. For obesity, it was 3 milligrams. So that also we don't have in full. Semaglutide injectable is approved already in India, but it's not available. So that's the state of affairs in terms of the medicines that are available for obesity management. When you talk of the quantum of weight loss with Aldi, if we see it's in different trials up to 5 to 8 kgs, predominantly works in people who do consume a lot of fat in their diet conventionally, either through their religious customs or their kind of familial practices. But otherwise, the quantum of weight loss is not that great. With liraglutide, again, 3 to 5 kgs at best in the doses that we have of 1.2 to 1.8. So not really much weight loss happening with the help of these drugs. Again, point to note here would be that liraglutide is a daily injection. This was another of the questions that was there in your pre-test. It's not a weekly injection. So why is it that we do not have many drugs for obesity and all this, while liraglutide was approved maybe 10, 15 years ago, and after that we've not had? And the reason is that the US FDA has been very strict about approving any drug for obesity. And what they say is that somebody should lose at least in their trial more than 5% of weight loss in 1 year before they approve any drug, or more than 35% of patients in a trial should lose more than 5%, and which should be at least twice than that of placebo. So US FDA has placed very strict guidelines for approving any weight loss drug, because it should have significant number of patients at least having 5% weight loss. In addition, they should have evidence for other cardiometabolic disease control. So it was one drug which was in 2021 that met this criteria, the injectable semaglutide, and that was approved in June 4th. After almost a large gap of 10 years, this drug was approved for weight loss. So let's talk about these novel GLP-1 RAs. And most of these GLP-1 RAs were initially actually studied for diabetes, but then they saw that in these diabetes trials, there was good amount of weight loss. So they started looking at these drugs for obesity management. So how do they work? Well, they do the usual GLP-1 knowledge that we have, that they are all insulin secretagogues. So these GLP-1 hormones would go to the pancreas, beta cells, and get more insulin, and therefore they would definitely help in improving glucose. But another main action of these drugs, who are GLP-1 RAs, is also on the brain, and they help to reduce appetite. And if you remember the slide I showed with respect to the diet that is modulated by the hypothalamic hormones, that's one of the main mechanisms of how obesity actually happens. And this is well targeted by these GLP-1 RAs. It does have other effects on liver. Therefore, they're also being tried in fatty liver disease, also have impact on intestine. That's predominantly responsible for the side effects that we get, and also improves glucose uptake in the muscle, improving insulin sensitivity. So that's how semaglutide worked. It was this particular trial that got it approved. This was the step 1 trial, injectable semaglutide, 2.4 milligrams given once a week, showed for the first time in the history a drug causing this quantum of weight loss, about 15 kgs, 15% in this particular trial. After this, several trials have been done with semaglutide, the step 1, 2, 3, and 4. And at this point, there are 17 step trials which are available, including a step teens trial, which is for children as well. So you see that most of these trials have shown significant amount of weight loss. Step 1 is essentially for weight management. Step 2 was in patients with diabetes. Step 3 in patients when this drug was coupled with intensive behavioral therapy. In step 4, they looked at a crossover design in which they gave the drug and thereafter randomized people in some who did not get the drug and some who got the drug. And you see that this drug has worked wonderfully well across the whole spectrum of diseases. Not only it showed reduction in BMI, but also in waist circumference. And also for the first time, we had body composition data available by the help of using anti-obesity drugs. None of the previous anti-obesity trials, including the ones which were done with liraglutide, had good body composition analysis. And this is particularly very important for our population, where again, I said that the BMI is not the best indicator, but body fat percentage is important. So again, there was a significant reduction in body fat, but also what I'd like to mention is that there was reduction in lean mass as well. So these drugs do cause weight loss, they do cause fat loss, but a little bit of that weight loss is also contributed by muscle mass. And that's where diet becomes very, very important. So we cannot say that we're just going to use anti-obesity drugs, bring wonders, and reduce the weight of the patient. It is very important to make sure that your patient gets a low fat and a good protein diet, and you do resistance exercises for that patient to improve the muscle mass. Otherwise, the patient just keep on, will lose weight, but will become sarcopenic, and that will cause another problem in due course. So definitely lifestyle is not only just the first step in the management of weight loss, it remains throughout the management, whether you do any of these drugs or you think of intragastric devices or even bariatric surgery. So again, this is an important point I want to highlight, that these drugs do cause a lot of weight loss. They cause fat loss, but they also cause a significant amount of lean muscle mass loss as well. Yes, they've shown to have significant reduction in visceral fat also, and this is another big problem that we see in our population. So yes, this drug is helpful there. Injectable semaglutide, though already approved in India, if you ask me when it is going to come, it is not coming for the next at least 1.5 to 2 years. So even though it is sounding like a very good drug, it's been off shelves in the US because it's been so well appreciated with respect to its weight loss, but it is not being able to match the demand and supply. So this drug is not going to be available in the Indian market for our prescription soon. But what will be available earlier is tirzepatide. Now, what is tirzepatide? We had semaglutide, which was GLP-1 receptor agonist. Now we have tirzepatide, which is a combination of GLP-1 and GIP. And when you have a combination of these two drugs, the quantum of weight loss that has been seen is much more. So like the other GLP-1 arrays, first the trials were done in people with diabetes. So the trials of tirzepatide, which were done in diabetes, are called the SURPASS trials. And they included patients who all had HbA1cs between 7 to 8.5%. But though their primary outcome was trying to look at how good the glycemic control is achieved in these drugs, that was there. But what they also saw was that the weight loss in SURPASS trials was phenomenal. So this is a slide which is showing people who have achieved more than 15% weight loss. So if a 100 kilogram person becomes 85, that's what it shows. And then the quantum of weight loss is really huge. The number of people who've achieved more than 15% weight loss, about 30 to 40%. So that's showing that this drug is extremely effective, not only for diabetes, but also for weight loss. And then they started doing trials exclusively in patients with obesity. So now this drug is approved not only for people with diabetes, but if my patient does not have diabetes, has only obesity, this drug can be prescribed. This will be available in India in the next couple of months. The quantum of weight loss, and this is the SURMOUNT trials. So the SURMOUNT trials are for obesity. The SURPASS trials that I showed initially were for diabetes. The quantum of weight loss with the help of these drugs is to the scale of 21%. And this is at the end of around 1.5 to 2 years follow-up, but the slope was still going down. So probably they would have had even more weight loss if the trial would have continued. This is the first time we've had an anti-obesity medication, which is kind of matching the quantum of weight loss that can be achieved with bariatric surgery. So this might be a drug that you might be prescribing a little earlier than semaglutide. That was the SURMOUNT-1 trial. In SURMOUNT-2 trial, they looked at people with diabetes, again had significant weight loss in people with diabetes. And a very interesting trial was SURMOUNT-3, which was recently published, looking at people who've already had an intensive lifestyle intervention, something that we do in our clinical practice. If we have a patient with severe obesity, we don't give them drugs on day one. We just counsel them about their lifestyle first. And most of these patients, if they follow the lifestyle, they are able to lose 5 to 10% of their weight loss if they really follow it well. But after having lost that weight, it becomes very difficult to lose more weight. And that's when you really think of a drug in people with morbid obesity. And in the SURMOUNT-3 trial, they used tirzepatide after lifestyle intervention. Again, the quantum of weight loss is phenomenal to the scale of 21%. So yes, this drug is also another drug that will be available soon. There's several trials in the market that are happening right now, including the ones with fatty liver disease, the CVOT trials, NASH trial. So all of these are happening, including for obstructive sleep apnea. So this drug might get permissions for different indications separately, but definitely one of the promising drugs. Moving on to the third drug, which is again likely to be available sooner, is a combination of semaglutide, injectable once a week, the same drug that I spoke about, 2.4 milligram once a week, along with cagrilinitide. Now, cagrilinitide is an amylin analog. All of us would have studied about pramlintide as an amylin analog. This is the next version, cagrilinitide, and combination of these two drugs in their phase 1 trials showed significant weight loss to the scale of bariatric surgery. So they went ahead with these phase 2 trials, and now also phase 3 trials have been completed. The primary endpoint here was again to look at change in body weight, comparing with placebo and liraglutide, again the quantum of weight loss, though in the phase 2 trial was about 11%, but in the phase 3 trial, which is yet to be published, the weight loss was again close to tirzepatide, up to 20%. So again, waist circumference changes were also quite significant. Getting down 9 centimeters of waist circumference is very good with help of these drugs. We at CMC now are doing head-to-head trials. We just started this trial last week comparing tirzepatide with cagrilintide. So all the patients in this particular trial do get a drug. We've also done Pioneer Plus trial, which is just now published, looking at semaglutide 25 and 50 milligrams. Right now, the semaglutide, which is available in India, is an oral tablet. It is available as 3, 7, and 14 milligrams. It is not approved for obesity, and that's why I'm not talking about it here. It's approved only for diabetes management. The quantum of weight loss that is seen with oral semaglutide is just about 5%. But the same oral semaglutide, if used in much higher doses in the scale of 25 and 50 milligrams, we did this trial here. We recruited 15 patients. There was no placebo, so I was sure that everybody is getting this drug. And at least 13 patients completed the trial, and all of them have lost about 15 to 20 kg. So yes, 25 to 50 milligrams of oral semaglutide might be approved for obesity management later on. But yeah, so these are the trials that we are talking about. I wouldn't complete talking about the drugs if I don't talk about retatrutide. I've so far spoken about GLP-1 RAs like liraglutide and semaglutide. I talked about dual agonists, that is GLP and GIP, like tirzepatide. Now, retatrutide is a triple receptor agonist in addition to GLP and GIP, even glucagon receptor agonist, and the quantum of weight loss with this drug is at par with bariatric surgery. So I think a good summary of all the drugs that currently have crossed phase 3 trials are on this slide. This is the paper we just recently published looking at diabetes, but I'll probably ignore that. We're taking you through all the drugs that we are having for obesity. At this point, US FDA has approved tirzepatide and semaglutide, injectable for obesity management. The most effective drug is a triple receptor agonist, that is GLP, GIP, and glucagon, causing about 25% of weight loss. Tirzepatide comes next, which is probably the first one which will be available later this year in India for use in patients with obesity, causing about 22% weight loss. Survodutide is a drug that is just a dual agonist, but an agonist of GLP-1 and glucagon, and this is subcutaneous. But the good thing is even oral GLP-1 RAs are now being tried and tested. They've gone through phase 3 trials. Oral GLP-1 RAs, I already talked about oral semaglutide, 25 and 50 milligrams, and also another oral tablet called orforglipron, which is another oral GLP-1 RA, which has been tried for obesity causing weight loss. So these are the drugs that are in the pipeline of different trials, but these are those which have crossed phase 3 trials. If you look at phase 2, there's another big galaxy of drugs which are there in the market. Probably every other international multinational company is making an anti-obesity medication right now, and you would see a flurry of these in the market. It's important to know about these newer updates, but also it is important to know how we have to use them in practice once we get it and what we do. So as I mentioned before, that we don't just go by BMI. So it's just not anybody who's got a BMI of 25, 27, 30. We are going to start all of these drugs. As I mentioned, first line would remain lifestyle. But overall, understanding obesity as of today, we are moving away from just looking at BMI and numbers. We're looking at trying to understand how we can look at a more comprehensive way of evaluating obesity, not just by looking at waist circumference and BMI alone, but something like an Edmonton obesity staging system, which is a simple staging system. I'll take you through this staging system. It's classifies patients of obesity from 0 to 4. So I'll give you an example. I may have a patient who's got a BMI of 28, not in the morbidly obese range, but she comes to our OPD on a wheelchair because she's got severe osteoarthritis of the knee. She has diabetes, she has hypertension. She has obesity related problems, but her BMI is not more. But if I classify her in this particular staging system, I would classify her in somebody who's got moderate or maybe even severe complication of obesity. So she would have stage 2 or stage 3. On the contrary, I may have a patient who's got a BMI of 35, a very happy-go-lucky patient comes and says, Doctor, I have no issues with obesity, it's the weight, I have no knee pain, I have no diabetes, hypertension, all the blood work is normal. And in that case, that patient might be in stage 0, or if she has pre-diabetes or some borderline hypertension, will have stage 1. So irrespective of the BMI, I may be able to stage these patients in different levels. And if these patients just have preclinical factors, so if your patient with obesity just has pre-diabetes, pre-hypertension, or just mild functional disability in terms of mild knee pain, but is able to do all her daily course, then I would put her as stage 1. I may have a patient who's got florid known diabetes, known hypertension, known dyslipidemia. So that patient would have stage 2. It's not only the medical problems that we're looking at, you're also looking at the psychological aspect and the functional aspect when you're using this classification. If the patient has complications, so if I have a patient who's got diabetes, diabetic retinopathy, nephropathy, hypertensive retinopathy, so these are complications of the diseases that the patient has, and that would be stage 3. And if there are end stage complications, patient on dialysis, patient has had, vitreal hemorrhage and requires, treatment in terms of laser therapy for the diabetic retinopathy, so they would be stage 4. So why is the staging system important? This is an interesting study which was done using the NAINS database cohort. Again, a large follow-up of over 200 months, over 5 years they've looked at follow-up. If you follow up the same patient just with the help of BMI, you would not be able to predict mortality. But looking at the same patients, if you stratify them with the help of an EOS staging system, you can predict who is the patient who needs more severe or more acute care. In our OPD, this is again data from our clinic, most of our patients in the obesity clinic would have stage 2 and stage 3. And now the guidelines are very clear. They also tell us as to when you have to use medical management. It's not based on BMI. You may have a patient who's got a BMI of 29 or 30, but still may be having your stage 2 and 3, and then you can use medical therapy in them. Otherwise, the standard guideline was always in the Indian stage that we have people with BMI of more than 27, you can consider medications. What do you do after you start any of these medications? You have to follow up these patients every 3 months. Most of these drugs should cause at least 5% weight loss in 3 months. And if they do not cause 5% weight loss in 3 months, despite the patient taking the drug and the lifestyle advice that you've given, then they would be called as non-responders. Another very common question that is asked, so if this patient loses significant amount of weight with the help of these drugs, do you stop them? The answer is no. The answer is that you treat obesity like any other chronic disease. Like if you have a patient with diabetes in your practice, you've got a patient who's got an HbA1c of 9%. You're going to start on anti-diabetic medicines. In 3 months, the HbA1c is 6.5. Does that mean you're going to stop the medicine? No. The moment you stop, the HbA1c will be back to 9. Similarly, for obesity, this was data which was published from the STEP 4 trial in which they stopped semaglutide in one arm and continued in the other arm after having significant weight loss. And they saw that if you stop the medicines, like in any other chronic disease, the weight will go up, which does add a significant concern to our population in terms of cost, because some of these drugs are going to be expensive. Though a lot of generics are being made, semaglutide injectable is going to lose its patent next year. So we will have cheaper drugs in the next 2 to 3 years, but still these have to be continued long term, is what the current literature says. Also, when we compare obesity medicines, what we've had in the past, we've had several medicines. Some of us, I'm sure, have used some of these medicines 10 years or 15 years ago. But what we see now that the current drugs have very good response rate. So 91 out of 100 people would respond in terms of good weight loss with the help of these drugs. And this kind of response was never seen before with any of the other anti-obesity medications. What is also important for all of us as physicians is that when we manage these patients with obesity with these anti-obesity medications, it is important that we also look at the other medicines that the patient is taking, because these patients often have a lot of comorbidities. There's no point giving another drug for something else which is increasing weight, and on top of that, you're prescribing anti-obesity medicine. So it's important to review the other medicines. For example, for diabetes, at least give a weight neutral drug, if not a weight losing drug. Similarly, for blood pressure, for contraception, for depression, many of these patients do have underlying psychological issues, not only depression, but other kind of psychotic problems. If you cannot change those drugs, refer to the specialist asking for a weight neutral drug, because yes, a lot of these patients do have underlying psychological issues. Again, this is data from our clinic, which shows about 30% of people who have severe obesity have an underlying psychological problem. So The message here is not only just think of anti-obesity medicines, lifestyle is first, but also look at the other medicines and try and give whatever is either weight neutral or weight losing in terms of the other medicines. Before I close, also talking about the newer aspect of genetics that is there. So we always keep having the debate whether obesity runs in the family or nobody runs in the family, and that's why everybody is having overweight or obesity. But yes, especially in younger children, in people who have young onset obesity, and this becomes again very relevant in our population where we have still significant amount of consanguinity, especially in our area and a few of the other South Indian states, we do still have a lot of consanguinity. And then it is possible now to do genetic tests in patients because cost has really come down with the help of using NGS. So when in your practice would you consider doing a genetic test in a patient with severe obesity if the age of onset of obesity is less than 10 years, if they have severe obesity and family history of severe obesity, which is young onset, family history of consanguinity. Some of these children have hyperphagia. Many times they present to us even at 20, 25 years of age because nobody has really, diagnosed them. If they have developmental delay or visual impairment. So any 2 out of these 8 criteria, if they are present, you should ideally think of a genetic cause of obesity. When we looked at data from our clinic and literature-wise, the most common one is MC4R mutation. And believe me, the people who we've seen and also the literature tell us that those who have this kind of a mutation don't really have big time mental retardation. They're very bright children. They're just very tall. They're very obese. They have hyperphagia, but that's about it. So many of these children who have this young onset severe obesity at the age of 5 years have very, very high BMIs. It is important to think of genetic cause. In our data that we looked at, about 16% of people who met this criteria have a genetic mutation. But why this becomes important today is today there are newer drugs which target specifically these mutations. Drug called setmelanotide can be used in people who've got an MC4R, LEPR, or LEP mutation. The quantum of weight loss with the help of these drugs is about 20 to 25%. And so for that one child, if you are able to diagnose and able to prescribe this, that it makes a huge difference for that child because otherwise lifestyle therapies would be very resistant in these young children who have a genetic cause. So I think that's pretty much it what I wanted to share in terms of the newer updates in obesity. What I spoke about is that yes, obesity is a big problem. It's a growing problem. All of us have to be aware as to how to manage it because patients do come nowadays just for obesity management, and you in your practice would see large number of patients just coming for obesity management. This is a growing problem. Definitely there is a need of anti-obesity drugs after, not only after, but also along lifestyle management. Lifestyle remains throughout the obesity management course. Several newer targets for obesity management are being recognized. GLP-1 RAs stay I would say, are there to really, really provide good amount of weight loss. Many of them are very effective. We have some of them which are already approved, but soon getting more in the pipeline. We talked about the indications for starting these medicines, not only dependent on BMI, and we have to look at the overall comorbidities. Things like Edmonton Obesity Staging System are helpful in classifying patients with obesity. And last but not the least, there's an emerging role of genetics as well. And there are new gene-specific drugs which are increasingly becoming available for management of obesity. So I would stop here. I would be happy to take any questions. If you have no questions, then I'll ask questions. So you may ask.
Mechanistically, how do you bring in the GIP receptor to treating obesity? Because classically, we were under the impression that GIP is something that increases fat accumulation as opposed to GLP-1 and amylin and glucagon. The other three work by reducing your appetite, blah, 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 in addition to your incretin